Thank you, Dr. Marino, and thank you, Dr. Sarnicola, for the invitation. So I'm going to present a case here of a 76-year-old patient who presented with decreased vision in the right eye more than left, with a past ocular history of Fuchs, history of post-cataract surgery, also has some age-related macular degeneration, which was noted to be dry in the past. And with limited impact on vision. Past medical history significant for myocardial infarction, leukemia, which is currently in remission, and COPD. On patient's examination, the best corrected vision was 20/60 in the right eye and 20/50 in the left eye. The rest of the exam externally was normal. On slit lamp examination, the patient had an exam consistent with his Fuchs, with 4+ Gutti, mild corneal edema, and again, pseudophakia. So the diagnosis is Fuchs corneal dystrophy. The patient underwent Descemet stripping automated endothelial keratoplasty. The surgery was uncomplicated. The surgery was performed using pre-cut tissue from the eye bank. The patient presented 1 day after surgery with no complaints. The vision was 2300. The graft was attached with mild stromal edema, some mild central epithelial staining, mild AC reaction, and still a residual air bubble measuring about 10 to 15%. The patient was started on prednisolone drops 4 times a day and ofloxacin 4 times a day. The patient came back 1 week after surgery with vision improving to 2150. The graft was attached and clearing. The patient was continued on prednisolone QID, and the ofloxacin was stopped. At the 1 month post-op visit, the patient presented complaining of some mild foreign body sensation, otherwise no significant pain or light sensitivity, was using the prednisolone as prescribed, and had vision improved to 20/25, and the pressure is 14 with the clinical finding that you see. So the question is, what do you think is the most likely diagnosis? Okay, so maybe we can move on. Could show the results. So most of you thought it was choice number 2, although there were responses that varied, maybe relatively equally. Let's go back to the slides. So the differential diagnosis in this case does include, go back one more, epithelial ingrowth, which may present after Descemet stripping endokeratoplasty, although it may not present as prominently just a month out. This is due to epithelium that may be from the donor tissue or the recipient that is dragged in at the time of surgery. It could be a residual, a cyst that can form in the interface, even with layering of cells as the epithelial cells degenerate. Certainly infectious keratitis is in the differential diagnosis as well. It could be a peripheral sterile infiltrate, or sometimes just even foreign bodies that could drag in, or meibomian gland secretions at the time of surgery. So at the 1 month postoperative visit, there was a loose bicral suture from a scleral tunnel incision that was removed. One thing I did not mention earlier, that the donor rim culture was positive for Candida glabrata. At this time, the corticosteroids were continued 4 times a day with close monitoring. So the patient comes back, was supposed to come back 2 weeks later, but came back 3 weeks later, complaining of continued mild foreign body sensation, still no significant pain or light sensitivity, but the best corrected vision had decreased to 20/50, but otherwise no cells were found. And here's the clinical photo from the exam, and I'll show you side by side what the patient looked like a month after surgery and now 3 weeks later. So this peripheral infiltrate has gotten bigger, and now there are clearly keratic precipitates that are present on the endothelium. So next question is, what would you do at this point for this patient? maybe we can stop and show the results. So the responses are more in favor of either using topical antibiotics or topical amphotericin at this point. So move on to the slides back again. So again, here were the options that you had. So at this point, the decision was made to start topical amphotericin given the positive donor rim culture, as well as oral fluconazole, but continue the topical corticosteroids still at 4 times a day. The patient comes back 4 days later. At that point, the decision was made to remove the graft and culture the antechamber fluid, as well as use intracameral amphotericin as the dose listed here. Post-operatively, the cultures all came back positive for Candida glabrata, the same as the rim culture. The patient was continued on topical amphotericin every hour, which was slowly tapered over the next few months. Oral fluconazole was continued for several weeks till clinical response was noted. The topical corticosteroids were continued. Fortunately, no infiltrate was noted in the recipient cornea. So 2 months after treatment, no recurrence was noted, although the patient now had corneal edema that was fairly prominent. So a repeat DSEK was performed with placement of a donor disc. And this patient is now about 15 months out, had back to best corrected vision of 20/25 with a clear cornea with no recurrence of infection. So I wanted to bring up the topic of fungal keratitis because this is something of concern, especially in the setting of endothelial keratoplasty. In general, the studies have shown that corneal button contamination can vary quite a bit, between 11 and 39%, with a large study from Wilhelmus in the past showing 14% of positive rim cultures with 0.2% developing endophthalmitis. There was a recent Eye Bank Association of America committee led by Dr. Tony Aldave that looked at the same issue and reported a positive culture rate of roughly about 0.2%. However, in their study, they noted that patients who had endothelial keratoplasty had a 17% rate of developing either keratitis or endophthalmitis. Previously, the reported rate of positive risk of infection was 1%, and it being 3% for fungal cultures. And one of the things previously noted was that if the mate culture was also positive 73% of the time if the patient who had developed an infection was positive, and the conversion of infection in the mate was 67%. The treatment in these cases needs to include antifungals such as topical amphotericin or voriconazole, and often they need to be supplemented as well. Dr. Elmer, too, has published a nice case series on looking at use of intrastromal use of amphotericin, showing good success, but oral agents can be used. Many of these patients may require penetrating keratoplasty, which can remove the whole infection and may speed up the visual rehabilitation. However, we know of all the complications that can occur, including recurrence of infection, high rate of rejection, synechia, and so forth. Of course, we know all the advantages of endothelial keratoplasty, but the concern there is that if you repeat the surgery, that you may harbor the infection still and may not be adequately treated. Therefore, a staged approach may be beneficial in these cases where you can treat with antifungals intracamerally, possibly intrastromally, and topically, and then go back and place an endothelial keratoplasty, as in this case, to avoid having to undergo penetrating keratoplasty. So in summary, fungal keratitis after EK is rare, but is of significant concern because of risk of loss of vision and loss of the eye. Donor rim cultures can aid in early management of fungal keratitis, and intrastromal injections of antifungals may allow adequate treatment of interface keratitis. And rather than simultaneous, a sequential approach may be better. Thank you.
Thank you very much.